time. I request Dr. Rohit SAXENA to present his talk on DRS customized approach. Dr. Rohit SAXENA is from RP Center, Professor of Ophthalmology.
Thank you, AIOS, for the opportunity, and it's an absolute pleasure to be here. We can start the moment the slides come on. They are there. Thank you. So I'll be talking about Duane's retraction syndrome. And next slide till the time I get charge over here. Yeah. Great. So the essential thing for management, the most important thing is to understand the pathophysiology. And just a quick brief about it, Duane's is extremely interesting. Its presentation can be very, very unique. Of course, it's now part of a comprehensive overall congenital cranial dysinnervation syndromes, and we get a lot of different kind of dysinnervations, and this is one of the most common dysinnervation. The basic pathology is nil or subnormal innervation to the lateral rectus from the sixth nerve. The lateral rectus gets abnormal innervation from the third nerve, the medial rectus subnucleus, essentially. Therefore, we also need to remember in our management that there is some amount of varying degree of subnormal medial rectus innervation also. So even though it's an ESO-Duane's that you start off with, the medial rectus is still underperforming because the number of fibers that are coming to the medial rectus would definitely be a little less than what it normally would be, because some of them go to the lateral rectus. And then overall, the different presentations are because of the secondary muscle changes. So you may have theoretically a fair amount of similar pathophysiology, but we'll see the wide variability in the presentations that we're going to get. And each case will therefore require a unique approach. We need to remember that our aim of surgery can be to reduce the deviation in primary gaze, to eliminate the abnormal head posture that the patient may have, the disfiguring retraction that may be there with or without the presence of shoots. So we'll just run through a few set of cases. This is an ESO-Duane's. You can see the narrowing with the palpebral fissure and the abduction deficit. Good stereopsis, so an ESO-Duane's. Now, this is something that we can overall remember what we're doing. Options are increasing with time as new and new surgical techniques are being discussed. But if you have a small esotropia to start with, you can do a small medial rectus recession, or you can do a vertical rectus, an SRT, IRT, or a split vertical recti transpositions. If the angle is more, you may have to do both. You can do a asymmetric bimedial recessions, or you may do a small medial rectus recession with a vertical rectus transposition. Co-contractions will require that you have to tackle the lateral rectus also, because that is the source of the co-contractions or abnormal firing of the lateral rectus. And of course, bilateral, you may have to kind of do both the eyes and manage each eye individually. So in this child, we did the involved eye, small amount of medial rectus recession, good primary gaze alignment, but you can see that there is an adduction deficit. In a comitant squint, had you done 5 mm of medial rectus recession, you wouldn't have seen any adduction deficit. But in a Duane's, you are very likely to see, it may get a little better with time, but the adduction deficit is there because, as I mentioned in the beginning, the MR is still a theoretically paralyzed muscle, and you've weakened a paralyzed muscle. So it's important. That's why we generally have very minimal or very small amount of recessions we do for the medial rectus because of the adduction deficit you're going to see. So do not do large medial rectus recessions. It does result in adduction limitation. If there is a significant amount of retraction that you see, if you do just the medial rectus recession, you may in fact have a synergistic divergence in the post-op, which will be very, very bad, or the splits, and therefore you may have to do the lateral rectus also in a case like that. We'll see. So another child with ESO-Duane's, you can see the amount of deviation was greater. In this, we did a very small amount of medial rectus recession. I generally would do the magnitude of medial rectus recession depending upon the force duction test. So my aim is just enough MR recession to free the force duction test, and along with that, we did a superior rectus transposition. I do not add a posterior fixation suture to the transpositions SRT or IRT, which I do in Duane's, although I do this, I add a posterior fixation in a sixth nerve palsy. So essentially, we still get very, very good results if you do a vertical rectus transposition along with a small medial rectus recession. You may get a small amount of adduction deficit, but it's usually less. So advantages of transposition would be you do get, like you would see in this case, you can see a significant abduction that you can get. So this is an advantage of doing a transposition procedure. Less amount of medial rectus recession is required. Possibly you may have less amount of post-operative drift or recurrence of the ESO, but do not plan SRTs or vertical transposition if there is significant retraction. In fact, at that point, you may have to do a lateral rectus recession. We've done SRT with adjustable medial rectus recessions versus both muscle transpositions, vertical rectus transpositions. The results were comparable, and therefore you could choose either. In lateral rectus, resections have been described. Small amount of resections, they say, is possible, especially if there is not significant retraction to go off with. But remember, even if you do, I don't have any experience in that, but it has been reported, so I'm just mentioning it here. But do a very, very small amount if there is a modest amount of esotropia you want to correct for. But definitely not if there is co-contraction, because it's going to worsen the co-contraction. This was the case of bilateral esodwans, and in this, we did a little larger amount of medial rectus recessions to start with, because of the fact that the angle was very large, so modestly greater than I would have normally done. But again, it's important to operate each eye based on the amount of angle that is present when the patient is fixing with the other eye. So that's an amount of deviation you have to check for. This was a child with esodwans, small ankle ESO, but a retraction. So in this case, we had to do differential recession of both the medial and the lateral rectus. So the medial rectus was recessed to correct for the esotropia, and the lateral rectus was recessed to correct or to manage the retraction. And that is essential if you are doing, if there is retraction in a case with esodwans. Otherwise, as I mentioned, you're going to land up with an exotropia in primary gaze or a synergistic divergence. We'll quickly go on to exodwans, and this was a very severe exodwans. You can see the severe retraction that is there. In attempted adduction, the eye is almost disappearing in the lid. So shoots and retraction often frequently accompany exodwans because the lateral rectus is also very tight. So again, options available would be a large lateral rectus recession, a Y-split if there are shoots, and of course, a major option can be you can do a periosteal fixation of the lateral rectus, which theoretically is like an infinite recession of the lateral rectus. So you've done a very, very large recession. So in this case, we did the lateral rectus periosteal fixation. You can see that there was a modest amount of abduction, which is lost, but there is very good alignment, and the retraction and the shoots has completely disappeared. So you get a good effect if you do periosteal fixation in cases like this. Again, another patient in which we did periosteal fixation, but in this we added a vertical rectus transposition. The essential reason why we did that in this case was that there was a fair amount of abduction in this patient. We have seen, after doing a lot of cases of periosteal fixation in Dwan's, we realized that about a third of them would go on to develop an esotropia over time, early or late. And among the reasons were that there was some amount of normal lateral rectus function seen by abduction in the preoperative period. So these patients have a risk of going into a consecutive ESO, and for them, either as the same intraop in the first stage or a subsequent stage, you may require to do something for the consecutive ESO that can develop. So essentially, if there is abduction present, you may have to add a vertical rectus transposition in these patients. Exodwans with severe shoots, you can see the severe amount of globe retraction. Remember, sometimes the retraction may be present in primary gaze itself, and that may be the cause for the hyper or hypotropia, and you may not require a vertical muscle transposition surgery in that case. So first, release the lateral rectus, make sure that the FDT is free, you've removed the co-contraction, and then see if there is any residual vertical deviations. Sometimes that may be also due to the inferior oblique overactions that may be there. Finally, orthodwans, you would not touch unless there is retraction. And if there is retraction in orthodwans, then you will have to do again differential recession of the lateral rectus and the medial rectus so that there is no consecutive deviation in the post-op period. So you only do surgery if there is significant retraction in orthodwans, and that is the only indication for intervention. So take-home message, you need to have very clear indications. You need to discuss with the patient that normal ductions and versions cannot be achieved. So the patient must be aware that this is going to remain post-op. And of course, essentially, we aim at increasing the area of primary of binocular single vision, and a lot of things remain to be desired. So thank you very much for the opportunity.
Thanks, Dr. Rohit. It's like in each Duan's case, we have to put on our thinking cap, and it helps